Good evening again. For those just joining us, welcome to the CPAN weekly clinical meeting webinar. We're happy to have you here. So we're going to start our webinar with a quick opening prayer, and I would like to call on our estimable Dr. Arinola Joda to take the opening prayer. Thank you.
Good evening, everybody. Let's pray. Can you hear me?
Yes, we can.
All right, let's pray. Our Father and our God, we just thank you for this opportunity to learn again. We thank you for the wisdom that you will cause to be shared in this meeting. We thank you for the grace even to be learners again. We ask that the information that we'll hear today will help us to be better pharmacists and better clinicians to the glory and the praise of your name. Accept our thanks and our praises, for we pray in Jesus' mighty name. Amen.
Amen. Thank you for that, Dr. Jordan, FPSN. So we're going to start. We are going to start with introduction. I'll first introduce myself. My name is Okame Okavai. I'll be moderating this meeting, and we are going to have today's topic is going to be taken by the Drug Information Pharmacists of Nigeria group. Before I call on the speaker, I would like to recognize some of our estimable people present. Everybody's estimable, but I'd just like to shout out to some people. So I want to recognize the executives of the Clinical Pharmacists Association of Nigeria, ably led by Dr. Joseph Madu. I would like to recognize the Drug Information Pharmacists of Nigeria group, led by our pharmacist Folashade Lawal, FPSN. I would also like to recognize members of the DIPN group that are present. I would like to recognize the fellows of the Pharmaceutical Society of Nigeria, the WACP, WAPCP. I would like to recognize professors on the call. I'd like to recognize heads of departments and all participants. You're all welcome, and we are happy to have you here. So I'll go on and introduce the speaker from the Drug Information specialist group. The name of our speaker is Dr. Rukayat Mohammed Adamo, B.Pharm, M.PharmD, M.PSN, M.CPAN. She's the Chief Pharmacist of the Federal Medical Center, KEFI. She's the Head of Inpatient Pharmacy, Federal Medical Center, KEFI. She's the Secretary of CPAN, Apex School of Experts. She's the Secretary of Pharmacy Training Committee, FMC, KEFI. She's the Secretary of Drug Information Group Training Committee. She's the Deputy Coordinator for Nasarawa State CPAN. She's IDF certified. She's an IDF certified diabetes educator. Again, Dr. Rukayat Mohammed Adamo. But before she takes us through her lecture, we would like to call on the head of the able head pharmacist Folashade Lawal, FPSN, to give us an opening remark. Thank you.
Okay, thank you, Pharmacist Okame. Pharmacist Folashade Lawal is not on the call currently,
okay,
but I can stand in for her. Yeah.
Okay.
Briefly, a Drug Information Pharmacy of Nigeria started in 2020, and the steering committee is chaired by Pharmacist Folashade Lawal, FPSN. Our mission are to build capacities of members, promote the use of information technology and clinical tools for best pharmacy practice. And our vision includes the promotion of specialization in drug information, provision of evidence-based and up-to-date drug information, promotion of safe and effective use of medicine. Our training was based on the resource titled Drug Information, a Guide for Pharmacists, with 27 modules. The first cycles of the training came to an end in November this year. And towards the tail end of the training, more members joined the group. Therefore, our plan is to restart the training in February 2023, using the latest edition of the training guide. We give thanks to God Almighty for his support and guidance. And with regard to tonight's presentation, it is loaded and promises to be very impactful. We therefore enjoin us to relax and pay full attention. Thank you. Over to you, the moderator.
Thank you, Dr. Ibrahim Bello. Without much ado, I would like to call on our speaker to give her, to take her lecture. Thank you.
I don't know if I'm audible enough.
Yeah.
Yes, you are.
Okay. Good evening, everyone. Thank you for having me tonight. Let me share my slide. Okay. Good evening once more. As pharmacists, I know we are always asked to provide responses to a variety of drug information requests daily, whether it's a formal request or in an informal manner, maybe from a phone call from a friend. Whichever way, it's always a drug information request. So tonight, hopefully, I'll take us through a systematic approach to answering such drug information requests. As means of introduction, actually, we all know that it's an essential component within the pharmacy practice for us to be able to respond to questions asked by healthcare professionals or the general public, because it's not only healthcare professionals that ask questions. We have questions from laymen, we have questions from co-workers as well. So drug information requests can actually be patient-specific. We can have questions regarding a particular patient. It could be for academic purposes, that's for educational purposes. It could also be for population-based, whereby it is to aid in the decision-making process for evaluating medication use for groups or group of patients. And our main goal, whenever we're trying to respond to such requests, is to enhance the quality of patient care, to improve patient outcomes, and to also ensure that there's prudent use of resources. So according to the American Society of Health System Pharmacists, to be an effective provider of drug information, the pharmacist must, in addition to other skills, be able to use a systematic approach to address drug information needs. Even though a systematic approach has been there, but a new one, a structured approach is coming up, is evolving, but the systematic approach is still most widely used to date. So now this brings us to the question, what exactly is a drug information request? Because looking at the screen, you can see some series of questions. These are sample of questions that I got from our drug information unit. Actually, these were true life questions that were asked. And one might wonder, what exactly is a drug information request? It is nothing other than just a question regarding any medication or therapy. And the person requesting for that information can be anyone. So please, I would like to call on our participants that you can attempt respond to any of these questions at the chat box. At the end of this presentation, we'll review these questions as well. So any form of question, maybe if I should ask now, if not because we're online, if I were to ask, I know everybody at least will have one or more questions that someone has asked, either directly or indirectly. Maybe it's just a friend that asks you, what exactly is this drug used for? How would you respond? I know we're fond of just responding. Maybe someone walks up to you with a pack. Like this question number one, someone came up with a pack of TLD, that's tenofovir, lamivudine, and dolutegravir, and asked, pharmacist, please, what is this drug used for? Then the second question actually was, an aunt of one of our intern pharmacists that called her. The aunt is a nurse. So she called the intern pharmacist, and that's the question you can see there. Even though it's not comprehensive, I didn't put all the details because of it's a slide presentation actually. And the third one was a patient that came up to our drug information unit and was asking for how long should he use lamivudine for hepatitis B. So why exactly are we having this particular presentation? That is because as pharmacists, irrespective of your site, irrespective of your practice, you can apply drug information services. Yes, there are some other specialized drug information services that only the Drug Information Center can do. But when it comes to responding to drug information requests, whether you're in the hospital pharmacy, community pharmacy, pharmaceutical industry, the academic, or wherever your professional, your type of practice, you can always respond to a drug information request. As an academic drug information request, for instance, one might wonder, what will a drug information unit be doing in an academic institution? Most of the time, sometimes you get questions from your clinicians in the facility as well. Or if it's in the industry, for example, pharmaceutical industry, what will they need a drug information services there? Sometimes also just do it for research purposes and also to get more information, because if you remember, the pack of every drug usually comes with a patient information guide. Then also there are some retail pharmacies. One might wonder, in a community pharmacy, then what do you do? You can, some community pharmacies actually can have online services whereby they register whoever gets any services from there, and then they always follow up, and there's a room for the person to submit his questions. So now, why do we need an organized approach? Because this is something that I think we've been doing daily, or always, we've been doing for a long time. For those of us that have been practicing for a while, we've been doing it, we've been responding to questions. So why exactly do we need an organized approach? Well, one thing we need to know is that it is not common for us to find comprehensive answers in the literature, because patients are usually individualized. So when you have a question, you might not really find exact response in the literatures that would suit that particular need for that particular patient. So you need an organized approach to come to your final response. Also, we need to realize that when we are asked questions, the requester could have also have access to whatever resources we had, maybe the internet. I know a lot of patients even use Google before approaching us. But then we need to realize, as pharmacists, our responsibility extends beyond just simply providing the answer. The question could be asked because the requester wants us to help in resolving the therapeutic dilemmas. And also, if we don't have some particular pertinent information, we should know that whatever information we give, if it's applied wrongly, or if it is not full, if we misinform the requester, it could be potentially be harmful. So now, if we're asked the question, should we go straight ahead to just give a response? No, there are questions that we need to ask ourselves. For instance, if someone asks you a question about a drug, What's the dose of amoxil? What's the use of, let's say, tenofovir? What's paracetamol used for? First thing you need to do, you have to ask yourself some questions. Some of those questions we need to ask ourselves before responding to any type of question, no matter how simplified we think the question is one, for instance, what's the requester's name? What's the profession? What's the affiliation? It's very important because the profession of the person would give you a guide as to how to respond. How can the requester be contacted? You have to ask yourself these questions. Does the question pertain to a specific patient? Is the question a general question, or is there a particular patient that this question is all about? Do we really understand the question? Have we actually identified the true information that is needed? Then we should ask ourselves, why is this question being asked? Why now? What are those things that could have generated this particular question? Have we gathered enough information, the background information needed? What exact information does this particular person need? And then when and how? How would he even apply it? In fact, we need to ask ourselves, what has the person done prior to this particular request? And then is there any other alternative that we can give? So now this brings us down to our main topic for today, the systematic approach for responding to drug information requests. Actually, this approach is an old approach. It was first developed in 1975 and is a technique that is used for drug information practice and also for teaching pharmacy students on how to effectively provide drug information. It was developed by Watanabe as a 5-step process, but over the years, it was modified into what is now currently called the modified systematic approach. It was modified first in 1987, and over these years, it has seen several modifications. And this particular approach has been shown that it promotes effective and efficient response to any drug information request, although we need to know that it might not be practical for all requests, especially if we have an urgent clinical need. And in this case, we might need to use the structured approach. Just like I said, it has been modified over years. The American Society of Health System Pharmacists have outlined a 9-step systematic approach in their guidelines on how to provide drug information. So here is a comparison between the 7-step and the 9-step by the ASHP. If you look at this particular, if you look at the screen, we'll realize that these first 3 points actually is involved in how well does the pharmacist truly understand the question. Even though they are really similar, because this is by ASHP, this is the modified systematic approach of 1987. Well, you can see that for ASHP, it was a little bit fragmented a bit. And I prefer this particular one because it makes it, the flow makes it more easier for one to follow. And this is the one I'm going to use for tonight's presentation. That's the 9-step by the ASHP, modified systematic approach. In the course of preparing this particular mini presentation, I came across this particular request. I'm sure a good number of us must have seen it on our CPAM platform. There was a request that came on the 30th of November, 2022. And the request was, good morning, colleagues. Please, I have this patient, a female 19 years, who has a blood pressure of 145 by 30 millimeter mercury. And I noticed that there was a skip in her rhythm of heart as it gets to 70-30. She's complaining bitterly of headache. Please, what is the best way to resolve this? So I'm going to, for the course of this presentation tonight, I'm going to use this as our sample request to take us through the 9 steps by the ASHP. On that same platform, on those different platforms, I'm sure if you could recall, we saw several responses. One was, what's the pulse rate? What are we resolving? Her diagnosis? Where is the patient located? Lack of history and data on comorbidity, refer. She should be referred to a cardiologist. Immediate referral, reason, high pulse pressure. These were several responses that came in an attempt to answer this particular request. So now, coming down to the ASHP modified systematic approach, our first step is identify the requester. What do we really do? What do we need? When we talk about identifying the requester, what do we need? We need to identify the requester. One, the name of the person. It's very important because you are going to document. So you cannot document something that is empty. You need a profession. Why do you need a profession? Because like I said earlier, the profession of the requester can determine how detailed or how would you respond to that particular request? How will you give the response? Are you going to make it comprehensive, more detailed? If it's a layman, for instance, the response will be different than when it's a professional asking. you need to know the location or the practice or the affiliation, because sometimes questions will come in. If it's from a research institute, for instance, you can assume that the request is going to be maybe used for research purpose. So you need to give an in-depth response. If it's from a clinical area, then you might, of course, believe that it could be for a patient. So you need to just give a summarized response. Then what's the contact information? Because definitely we need to give a feedback. So knowing the requester's demographics enables one to develop a response with the appropriate perspective. If it's a layman, if it's a pharmacist, if wherever, if it's a patient, a caregiver, then you have to determine the method for delivery. How does the requester want the response delivered? Is it verbal? Is it written? Is it by mail? So for our sample request, our first step, which is to secure the demographics of the requester, I'm sure you agree with me that the person asking that question is a pharmacist, so the profession is a pharmacist. I didn't write the name just because this is just a sample. I'm using it for just to go through. So I didn't write the name. Then the location is a pharmacy, I believe. Then the contact information is available on the platform. So the method for delivery is WhatsApp, because the request came in through the WhatsApp. So now the next step, we've identified the requester. What's our next step? The next step is to define the true question and information need. Now, this particular step is very vital, because if we don't identify the true question, studies have shown that a good number of responses that pharmacists give, if you didn't identify the true question, you might give in a different wrong response, not entirely what the requester wanted. So to identify the true question, you need to ask some probing questions of the requester, but we need to note that the requester might not provide those information for you beforehand. So you need to ask. You have to use your questioning skills to ask. For instance, you could ask, why is the question being asked? If someone asks a question, you need to ask, before giving the response, please, why is the question being asked? Does the question pertain to a specific patient? What are the circumstances that generated this particular query? Because once you are able to identify the true question, it helps in optimizing the search process. If you don't identify the true question, you might search wrongly and you give a wrong response at the end of the day. So now, coming down to our sample request, to define the true question, there were some responses again on WhatsApp. Someone asked, what are we resolving? Her diagnosis? And someone replied, yes, I think. So from here, you can see that someone is trying to first identify what exactly are we supposed to do with the request. So the question we ask is, why is the question being asked? So for our sample request, the question was asked because the requester needs a second opinion on the way to go about handling her patients. So now, the next question we need to ask ourselves is, what information is actually needed? The most appropriate line of action. The next question is, what are the circumstances that generated the query? Was it just out of the blue? What really happened? That is because the patient came in with a blood pressure of 145 systolic and 30 diastolic, and the patient is a 19-year-old with headache and skipped heartbeat. So is this particular question now patient specific? Yes, it's patient specific. So it means we have to tailor our response to this particular patient. We know it's not a general question. The person is not trying to ask about a blood pressure of this range, but is trying to ask about this particular patient entirely. So now our next step is, because we've already defined the true question and the information need. So now our next step is we have to obtain a complete background information. Now this is where a good number of times we miss it out, because when questions are asked, we don't actually obtain the full background information, and not doing that can actually give misinform us or mislead us. So because this particular step is the most difficult and critical step in the whole process, and we need to obtain some background information to individualize the response to meet the requester's need. To get this particular information, we have to get some pertinent information. We have the general information that we need to get, and we need specific information. For the general, usually we all know that whenever we receive a request or a question about a drug, it usually has to do with a patient or a disease or about a medication. So we need to gather this particular information from the requester. But for the specific questions, it depends on the type of the question being asked for the specific information that we need to get. So what information do we need? For the general information, this is not a comprehensive list because of the because it's a slide presentation. So we can get the more detailed questions in the drug information book, A Guide for Pharmacists, in the appendix section. So for the general pertinent information for the patient, one way to remember is we should remember our SOAP. You should gather your subjective and objective data. So everything we know about subjective data, the medication history, the demographics of the patient, age, weight, height, all those things. The objective data, review of systems, the labs. So if you remember those, you can remember what you need to get when it's patient related. For the disease, we have to now ask ourselves, because it might not really mean you ask the requester, but you have to gather this particular information. If the question is regarding, let's say, for example, COVID-19, treatment of COVID-19, if someone asks you, can I use, let's say, dexamethasone for COVID-19? So you have to ask yourself exactly COVID-19, what's the etiology, what's the pathophysiology, how is it diagnosed? Then come down to treatment to be able to answer that question. For the medication as well, we need to have information on medication, the medication being asked before we even make a response. For the specific information, like I said, it depends on the question being asked. Once someone asks a question, immediately we should be able to form a mind around the question. What type of question is it? Is the question talking about an adverse drugs reaction? For example, if a question comes in, can ciprofloxacin cause angioedema? We can't just go straight to answer a yes or a no, but we need to find out some things about the particular drug and the patient that was used. How was it used? Was it specific? Did you re-challenge and you saw that effect? If we think it's about adverse drug reaction, if it's about availability, this is a question that sometimes we get asked: is this particular drug available? You don't just go straight to say yes or a no, but you need to ask sometimes, what exactly are they trying to use it? So that in case at the end of the whole process, your response might be an alternative actually. So for therapeutic use, you will need to ask what exactly effect is desired. Is it for prophylactic use? Maybe if someone now asks you a question, can I use maybe let's say SP in pregnancy? So you have to ask first, is it for therapy, for prophylactic? Then before you can now say a yes or a no, since we know we can use it for IPT, but not for treatment. So if it's for drug interaction, someone asks you, these particular drugs, do they interact, or is there any interaction? It's not just enough to just go and say yes, just yes or no, but we have to consider some other factors like the age, like the health conditions, because sometimes you can have drug disease interaction. So we have to consider all those other factors before we give a response. Same thing go for poisoning. For dosage, if a question comes in for dosage, for instance, what's the dose of, let's say, for example, somebody can ask you, what's the maximum dose of paracetamol in a patient? Maybe let's say, what's the maximum dose of paracetamol? You can't just go and say, this is the particular milligram. No, but we need to ask, what's the disease? Is there any other drug that the person is taking? Maybe the person is taking over-the-counter preparations with paracetamol. So you see, in that case, telling the person to go on the maximum dose might not be the appropriate way to go. Or maybe there's organ function dysfunction. Let's say, for example, the person has liver cirrhosis. Then, of course, the maximum dose of paracetamol in such a patient will be lower. Maybe the question is now on therapy evaluation. Someone asks you, I've been on my drug. Like a patient approached us and approached me actually and said, I was on anti-diabetic, but it's not more working for me. So my physician wants to change it. So it's not just enough to just say yes or no, but you have to find out, was the patient actually adherent? You need to ask those questions first. What monitor parameters were followed to now determine whether, yes, it was actually working or not. Then if it's a question about compounding, you need to find out, because I remember there was a prescription that came in for compounding, and the prescription was for hydroxyurea. So, but we have to find out, this particular drug, can it be compounded? How should it be compounded? All these things you need to gather first before you provide a response. If the question is on pregnancy and lactation, for instance, you need to ask, what trimester is the person actually? Let's say, for example, someone asks you SP in pregnancy. You need to ask, what trimester? So that you don't say, yes, maybe she's in her first trimester. So you need to confirm some of these things. Like I said, it's not comprehensive. A more detailed listing of all the questions is found in the textbook there. So for our sample requests now, can we say that we have the complete background information? Well, I will say no. We don't have adequate background information for this particular request. So now, having obtained the complete background information, what's the next step on our modified systematic approach? it is to categorize the question. So why exactly, when we say categorize the question, what exactly do we mean? It means that once a question comes in, the pharmacist should be able to categorize the question. What type of question is it? Is this particular question a patient-specific question? Is it for a particular patient, or is it for academic purpose? And what type of question is it? And it's very important to categorize the question, because categorizing the question now helps us to find the appropriate resource to search. We have several resources available online, in print, and all that. So without knowing the type of question, how do you know which resource to search? Let's say, for example, a question now comes in let's say let me use the first example, one of the examples I used. Let's say angioedema in ciprofloxacin. If we are to check availability or MDEX, we might not really get that answer. We have to go to a search that is involved with adverse drug reaction. So it means we have to categorize this particular question as an adverse drug reaction question to know which resource to find. So these are some question groupings, a categorization of questions. We can have, maybe it's availability, drug identification category. Could it be drug dosing? Could it be drug interactions? Could it be a drug therapy question? Is it adverse drug reactions? Because we have several resource materials like Stockley's, for example, Stockley's book of drug interaction. That would only answer our drug interaction questions, but it cannot answer adverse drug reactions. For poisonings, we have stability. These are lists of questions categories that we have that you can group your question. Which category does it fall? So for our sample request, we can say that it is patient specific because it was for a particular patient. And for the type of question, I would say that it's a drug therapy question. It means that for our search, we'll have to focus here. If I was to search for that request in, let's say, MDEX, I would never get a response. If I was to search such a request in Stockley's, I won't get any response on that. So it's a drug therapy. So what we need now will be a drug therapy related resource materials. So we've categorized the question. Our next step is to perform a systematic search. So what exactly does this mean? It's very important for pharmacists beforehand, irrespective of practice, area of practice, to have our resources sorted out. I'm sure we are familiar with the tertiary, secondary, and primary resource materials available. So we need to have our resource materials sorted out. And one thing I learned is that if you have a mobile phone, there's this app, Aldico, which arranges your materials in a bookshelf manner, like a library. It's very, very, very good. I would recommend that we have it downloaded to sort out. Sometimes we might have electronic books and we'll keep copying same books because we are not even aware we had it before. But if you're able to have such an app, it will arrange your books on the shelf. We'll see it in the next slide, what it looks like. Then Adobe Digital Edition is for desktop. So how do we search? Because this is a very critical step. How do we search? If we're able to categorize everything, but the next thing, how do you search? We have to search tertiary. We usually start with tertiary, actually. Tertiary through to secondary and primary. But then when we are searching, it's very important for us to evaluate the literature. What does that mean? It means that if it's a tertiary resource material, you should be able to evaluate the timeliness of that material. How recent is that book, the publisher, the publishing itself? If you look at the copyright page of any textbook, we will see that there are always dates written. Maybe first print, this is a reprint, the dates are always written. The essence of that is to tell us how timely is that particular book reprinted or revised. Then also we should evaluate that book, the credentials of the author, the authors or the contributors. What are their credentials? Do they have the experience and the expertise to write on such a topic? It's very important. And then also the edition, a particular edition that we have, let's say, for instance, maybe let's say, just like at the beginning of the today's program, the deputy coordinator, Dr. Ibrahim, was talking about, we're going to use the latest edition of the Drug Information Guide. So it means if you have a tertiary resource material, which are usually textbooks and compendia, one thing we know about them, their disadvantage is that they could be outdated. So it means that one needs to find out what exactly the edition you have. Is this the latest edition, or how far back and outdated is that book? Then another thing to evaluate is the references. How updated are the references? Then for internet access, for internet materials, because a good number of times now some of us prefer to use online resource materials rather than using the textbooks. So if we're using internet resource materials, for that too, we need to evaluate. It's not every internet access material that we recommend. We have to evaluate for the authenticity of that particular site. Let's say, for example, Wikipedia. I wouldn't expect us to use Wikipedia for reference purposes for anything when it comes to responding to a request. Also, a blog. I wouldn't expect us to use somebody's blog because we need to find out what's the currency, how current is that particular internet or website. If it's usually updated, that's why at website pages, we'll see updated, maybe this particular date, next update is this particular date. The essence is that it gives you a guide to how current is this particular website. Then also who is sponsoring that particular website is very important. Maybe it's a promotional website. So we have to evaluate that for reliability of the information. So when we're trying to respond to any requests, it's always important to start with tertiary, which is a general reference, unless if we don't have, if it's not very current, or if the topic, it's a new topic. Let's say, for example, COVID-19 that came in recently. So for that, of course, we wouldn't expect to see much in a tertiary reference material. So we can go to secondary. And for secondary, we have to see that we tried, secondary research materials are usually those with abstracting and indexing, like PubMed, Cochrane, Embase, Medline, and the rest. So, and it usually links us to the primary article. So whenever we're searching on the secondary, we should also go with the most current index and then work backwards. That's in a descending order. Then for the primary, it's not always advisable to start with the primary because you need critical evaluating skills, and there is also high risk for bias. So if we're going to respond to any request, start from tertiary to secondary down to primary if we couldn't get the response from tertiary. And then also, it's very important that we compare the texts. Whenever we're responding to a request, let us not use only one text to make the informed decision. It's very important that we check other texts as well for consistency to be sure that the information is the same, irrespective of where you search. So this is what an Aldico interface looks like. For the purpose of this lecture, I just, these are some of the books we can see there. But then, like I said, it's very important that we sort out beforehand. So one of the things we can do using this part, when you click here, it brings this up, and then we can use the collection section to sort out your reference materials to whatever. If you are the one that love novels, sort your novels separate, your religious books separate, your pharmacotherapy separate, so that you have now list of your pharmacotherapy books separate. Once you click on your collections, you can go straight to your collection. But then it's very important to sort it out in this manner, because when you have a question, one of the key characteristics of a drug information request is that it should be timely and accurate. So once you sort out your references, if it is disease-oriented, you have your disease-oriented materials in a particular category. Maybe if they are drug-oriented, let's say MDEX, Martindale, BNF, Lexicom, these ones can be drug-oriented. So you can now sort out in your Aldico, for instance, you have your drug-oriented, disease-oriented, special population, so that if the question is regarding a child or a pregnant woman, just go straight to special population, and only the books under that category will be displayed on your bookshelf. These are just references that I put up, book references and online references, tertiary references actually, for different categories of questions that we can use. So like adverse drug reactions, these are the book copies, these are the online references. Although some of them need subscription, like MicroMDEX, Lexicom, Facts and Comparison, these ones need subscription for you to be able to access. So all these ones are just topics, questions, and the books reference materials that can always get. Let's say for therapeutics, J&G, Applied Therapeutics, these are textbooks. These ones are online materials. Up to date too, you need subscription for that. So now for our sample request, I would say that the resource material to search is disease-oriented, because if we group our materials into disease-oriented, all our needs to go is go to the disease-oriented section and then put a focus on diagnosis or treatment in internal medicine. So now for this particular request, I checked Harrison's principle of internal medicine, and what I found was that you can have very low diastolic blood pressure, even 0, in patients with chronic aortic regurgitation. So I also searched current diagnosis and treatment with cardiology, and what I found is that the systolic arterial pressure is increased, whereas the diastolic pressure is decreased from the aorta in aortic regurgitation. So, but then this is not enough. I need more information because I don't know if the patient had a focus of systolic of 145 and diastolic of 30. So we have to look further. There's a wide pulse pressure. Pulse pressure is just the difference between systolic and diastolic pressure. So checking this particular National Library of Medicine, I came across this particular article. So in contrast to age-related, because wide pulse pressure is actually more commonly in the elderly, but this patient is young, 19 years. So wide PP in our young patients is most seen with well-conditioned athletes. But remember, our patients, we don't have much background information. So I searched further, is there any other thing? So even though they said the pathologic variant is less common, but once you see it in young adults, it may constitute a telling marker of deteriorating cardiovascular health. So I searched under physiology now for pulse pressure to see if I could get anything different. And what I found out was that there are several causes for a wide pulse pressure: severe iron deficiency, anemia, atherosclerosis, hypothyroidism. But majority of these cases has a systolic pressure increased with diastolic near normal. But in aortic regurgitation, you have an increase in systolic pressure with a decrease in diastolic. So now this seems like a bit of a difference. So I searched for isolic systolic hypertension since the patient had 145 systolic blood pressure. So in Hypertension Journal by American Heart Association, the definition, of course, this is just to show us the definition of isolic systolic hypertension. But then what they found out was that in female sex, it is associated with a greater increased risk of cardiovascular mortality. So now, having performed this particular systematic search, the next step to go is to analyze the information. To analyze this particular information, we need to gather all the information we've gotten from the background information we've had. We need to be able to evaluate the information we got from all the resources, interpret it, combine all the information. But we shouldn't forget that clinical reasoning is very crucial because you should be able to merge whatever information you got. But then you can anticipate that other information need might arise from whatever information you provide. So coming down to our sample request, let's analyze the information. She's 19. This is her blood pressure, 145, 30 diastolic. The pulse pressure is 115, which is very high because the normal is 40 to 60. So it's very high. She has skipped heartbeats. So like I said, we found out that wide pulse pressure has several etiologies, but then most of them have a near normal diastolic blood pressure, except aortic regurgitation, which has a very low diastolic blood pressure. And since isolated systolic hypertension in the young is not uncommon, so we might have a focus on that since she's a female sex, she has also high risk of cardiovascular mortality. So now, what do we do next? Next step is to disseminate the information. Now, this is why at the beginning, you need to identify your requester because it tells you how you are going to formulate your response. Considering the background information, the evidence we've gotten, and the analysis we made, we've already decided from the beginning, how are we going to provide the response? Is it orally? Is it in written form? But then we need communication skills because how you communicate with the requester will now determine whether the person understands your final response or not. But then knowing whether it is patient-specific or academic will tell you the urgency of the response. So if it's for a particular patient, we know that the response that we're going to formulate should not be too detailed, and then it should at least be timely because it's an urgent request. But if it's for academic purpose or let's say for population base, then we can give more detailed. And depending on the profession of the requester, we might need to attach more evidence. And let's say if the requester is a clinician, for instance, maybe he's a physician, we might need to attach more reference materials than just a single response to the person. So for our sample request now, the possible response combining all the information we've gathered so far, I will say that the isolated systolic hypertension, though it's mostly seen in elderly, is not uncommon in the young. And also we have paucity of necessary data for this patient, but it appears that she has a wide pulse pressure with isolated systolic hypertension. Though there are several etiologies like exercise, anemia, hyperthyroidism, but the low diastolic that she has of 30 could be suggestive of cardiac origin. Therefore, the person needs to be referred to a cardiologist for expert care. And the essence of giving some of this information is because the requester, you won't want the requester to go back to start searching. You should have done all the searching and you just provide the final answer or information to the person. So you have to be a little bit, you have to give more of the data that the person would need. So now, after disseminating the information, the next step to go is to document. Like the popular saying, if it is not documented, it is not done. So what do you document? First, you have to document your request. You document the ultimate question, because sometimes the question that might come at the beginning might not be the same as the ultimate question. All your information resources that you used, so that for reference purposes, if somebody wants to use it later on, can always refer back to what information resources you used, the one that the information was found, the time you spent, because it won't make sense for you to spend 3 days or 4 days on a particular query. So the time spent, then how do you document? It can be paper-based, it can be computer-based. So why do we need to document? Because like I said, somebody could use it for future purpose, but we should not forget one aspect of drug information, that is the legal liability. Whatever information you give, you should document, because in case if there's anything that might arise, anything legal that might arise, you are covered. So now we've documented. The last step we're to do is to follow up. Why do we need to follow up? Just like we always follow up our patients, we also need to follow up. You have to follow back to determine the utility of the information provided. Did it result in any change in the medication? Let's say, for example, the question has to do with a medication used in a patient. The information you provided, was there any change, or was the patient outcome now improved, or any change, so that you now know whether you have to reassess or provide another information later and again. Maybe there's a new information that is now needed. So method of follow-up could be by mail, phone call, could be written. And we have several reasons. Like I said, it could be for feedback, also for the quality of the service that you give. So at this point, let me see if we had anybody that responded to any of these questions. No bad. Okay. So to conclude, I said I was going to come back to these particular questions. The first question, someone asked, someone told me to buy lamivudine for hepatitis B. How long should I take it? The first thing that will come to your mind is, okay, this is how long therapy of hepatitis B is. That is until there's seroconversion. But going through these steps with a particular person, with this person that asked this question, we realized that the drug was recommended to him by a friend. He didn't have any hepatitis B profile test done. All he had was hepatitis B surface antigen that was positive, and that was it. And a friend recommended lamivudine to him. So he wanted to just know how long he should use it. So our response to that particular person was that he needs to do a hepatitis B profile test first to determine whether he was in immunotolerant or immunoactive phase, whether he actually needs therapy. And we said lamivudine may not be the drug of choice for him, because of course we know there is resistance to lamivudine, and tenofovir is actually preferred now, or in some cases entecavir, depending on the renal function of the patient. But then we just told him that it might not be the drug of choice for him, and it could last a period of time. So we recommend that he see his physician, so that the profiling will be done and the appropriate medication will be prescribed. Then this particular one, like I said, it was from a nurse, an aunt of one of our intern pharmacists. So she said her mom had a TIA, transient ischemic attack. So when we searched the drugs, we found out was the initial question was check if the doses are okay for her. But our response now is not about the dose. If you look at it, there's nothing about the dose. That is because when we checked, we realized that there was drug-drug interaction between clopidogrel and omeprazole. So omeprazole needs to be changed. And then one of the things we realized when we asked regarding her TIA, we realized that the patient was self-medicating with celecoxib on her own, which we all know that COX-2 inhibitors have that risk of cardiovascular side effect. And it could be one of the maybe reasons that she had a TIA. So we advised her to stop medicating with celecoxib. So the other recommendations for the drugs, I don't want to put it there because of it's just a slight presentation. Then for this one, what is this drug used for? This is one of the most common questions we get asked as pharmacists. Someone can come up with a pack. So if this one, a patient, it was actually when we asked, we realized that the person requesting for the information was actually trying to find out about his friend's medication. He saw a pack TLD with his friend, so he wanted to find out what it's used for. So, and that is why we gave the response in an indirect manner, because yes, I know TLD is used for HIV, but since realizing that the question was coming in from a patient's friend, not the patient himself, so for privacy, because in as much as we are responding to drug information requests, we must maintain patient privacy as well. So we now told him that TLD is a combination of antivirals, and there are different viral infections. Like these examples we cited, just to keep his mind off HIV mainly. So, but we need more information from the patient to identify which one it was prescribed. And the essence of this was that if it was the patient that was asking, definitely he will come around. But since it's a patient's friend, so we don't know why he was asking, and we didn't want any issues to arise. So this was the response we gave. These are my references. So next time we receive a call and we do a systematic search, we should provide the appropriate response, and definitely our requester will be happy. Thank you very much.
Thank you, Dr. Rukayat Muhammad Adamu, for a wonderful lecture. We really appreciate what you've done. You've spoken to us about the systematic approach of answering responding to a drug information request. You've spoken to us about that you prefer the ASHP 9-step modified systematic approach. You spoke to us about when using you spoke to us about why, how as pharmacists, we respond to drug information queries from with regards to drug information. You spoke to us about the kind of people we would meet that would request this, that would ask questions. We'll have from the public, we'll have from healthcare professionals as well. You spoke to us about how when we are responding to a drug information request, that it's not just to answer the person off the top of our head. There's actually a system that we have to use as professionals to respond to such questions. Like I said, you spoke to us about the ASHP modified systematic approach, which involves one, identifying our requester, understanding the exact information our requester needs, especially when we've identified whether the person is a professional or the members of the public. You have told us to obtain complete background information, because the background information is going to determine how we respond. We categorize the question, we perform a systematic search, we analyze the information, then we disseminate the information, we document, and we follow up. You also gave us examples of questions that as drug information specialists we can come across, and some of the responses you gave to those questions. So thank you very much for this lecture. I want to call on open the floor rather to questions and answers. Because of time, we might not be able to take much, but let's see how many we can take. I think for now we can do 3 questions. If we're able to do more, we'll do more. But by show of hands, you please ask your question, and I would call on you to ask your question. Okay, so we have Dr. Joseph Madu with his hand raised. We have pharmacist Ifuchoma Winzu with her hand raised. So we're going to start with Dr. Joseph Madu with his question. Thank you.
Hello,
Dr.
good evening.
Madu. Yes.
Good evening. Please, can
Good
you hear
evening.
me well?
Yes, we can hear you.
All right. Mine is more of a contribution.
Okay.
I know that you may not give me the opportunity to speak again, but I want to appreciate the Drug Information Pharmacy Specialists of Nigeria. I can say that this is a very concise and straight to the point lecture, and I have gained a lot this night. Most importantly, let me use this opportunity to appreciate, I think, Professor Valentine Odili. I can see his name here, and he was my lecturer at the University of Benin during the PharmD course. He taught us drug information, and I think that it has done a lot to my life and the way I practice pharmacy. When he was teaching us, of course, I remember he said, somebody, for instance, comes into your pharmacy and asks you what is the dose of gentamicin, and people will just jump into saying it's maybe 80 milligram or to 240 milligram per day, and that's not right. And that thing has really guided us till date. Even what Dr. Rukayat has done this night, she has expatiated on all those things that I can say personally I learned during my days at the University of Benin during the PharmD course. But most importantly, I want to appreciate every person that has attended this lecture tonight. And I want to tell us that I was at an MCD program today at University of Port Harcourt, MCPD. And one of our past presidents of PESEN, an elder in the profession, was saying that pharmacists in Nigeria are doing very, very well. Currently, he was even saying that at a time, he and his wife thought they know so much. And while they were interviewing a pharmacist, a pharmacist they wanted to employ in clinical pharmacy, they even provoked the pharmacist, and they discovered that they didn't even know much, like what the young pharmacist was trying to present to them in clinical pharmacy. And he was saying, most importantly, that's why I just want to make this comment. The elder colleague was saying that in the next 5 to 10 years, the pharmacists in Nigeria are going to be one of the best pharmacists in the world because of what is currently happening. So I want to appreciate everyone. I know Pharmacist Okame, the moderator, I know she's a very excellent person. In fact, I didn't even know that she has been following us in what has been happening. I want to encourage everyone. I want to appreciate everyone. And I want to encourage all of us to please keep on keeping on. We are getting there, and we shall soon be acknowledged as part of the best in the world. Thank you very much.
Thank you, Dr. Madu, for your kind words. We have pharmacist Uchoma Wins. I don't know if she still wants to ask her. Her hand is down now. I don't know.
Pharmacist, I'm still here. Good evening, everyone.
Good evening.
Yeah, so my question, and thank you so much for the wonderful and very the strategic way in which you presented your case. And I'm so glad that you also used the example, your sample example was from a drug information question that came up in one of the CPAN platforms. I'd like for you to please address, if you can, scenarios where pharmacists are being pulled in to answer questions that border on diagnosis. In this particular case, it was clear-cut where this is something you need to go and see your go and see a cardiologist. But there are some cases where it is not clear-cut. It seems like something that can be done in primary care, but we're being roped into answering questions that make us now go into diagnosing. I think I'm a bit wary of that, and I'd like for you to please address it so that people are clear on how to answer questions that pull them away from scope. Thank you.
Thank you, Pharmacist Mabel. Pharmacist Rukayat.
Okay, thank you very much. Well, I think if I get your question correctly, it's regarding pharmacists diagnosing, right?
Sorry, I muted myself. Yes, pharmacists being pulled into drug information questions that start bothering on diagnosis. Yes, because there's a way, it has to be answered in a way that excuses you from making that diagnosis. I think that's where we now go into scope problems and hoping that we are able to clearly in our documentation and clearly in our answering those questions, take ourselves away from diagnosing. Because like I said, the case that was presented, go to your cardiologist. That absolves you of any litigations or anything that fall back. But in cases where it's, let's say, easy diabetes, hypertension, things that are happening in primary care, it may not be that clear cut, and you don't want somebody going to say, the pharmacist told me it is hypertension, or the pharmacist told me it is, when you start going to outside the scope, you start, meddling. I just, if you can, please.
Okay, let me attempt. Because I think this problem will come more of in community than in the hospital. So because in the hospital, of course, we know our place, and but with the community, that's where the problem will come more. So I don't practice in community, but I stand to be corrected. I think that there are some minor elements that I think we can actually diagnose and treat, but then there are some that's clear cut depending on how it presents. Because in as much as we are clinicians and we have the mandate to maybe diagnose and treat some common ailments, we have a line. So I think one of the first things we need to know is we need to know our line as pharmacists. Where does our line start and where does it stop? Because that's one of the, I remember like last week we were I was in a lecture with the physicians in our facility, and when they were talking about patient safety and something came up, and when we asked what the thing that came up was regarding, they said pharmacies want to go into, because we want to now compete with them and all that, but they have a line that they have to draw. Everybody's drawing a line. So I think also, yes, as pharmacists, if the person comes down to diagnosis, then if it's the one that legally we are allowed, maybe common ailments that legally as a pharmacist in the community pharmacy practice, you are allowed, I think it's okay if you go ahead. But if it's one that goes beyond our scope, then the referral, I think is the best way to approach it. I don't know if someone in the community have more to say to that, but that is my own thinking on that regard. Thank you. I don't know if I answer your question.
Thank you, Dr. Rukayat, for that for response. Pharmacist Windsor, I don't know if she has answered you satisfactorily.
Yes, thank you. I just wanted to call that out because I think it's an area that we usually would start stepping outside scope and maybe get into trouble. In this, I think I'm very aware that anytime pharmacists start making progress, there's something, it starts ruffling feathers, and you start finding the other members of the healthcare team get frustrated. And so we don't want to play into their ball. We don't want to play into their court. We want to be very mindful of what we say, how we address situations. That way we are not playing into their, because they are waiting. We are aware that we have, for lack of better words, enemies out there. We must be careful to remain within our scope. And our scope is very broad. Our scope is very, that viewpoint that we have where we look at a patient from the viewpoint of medication and treatment is very broad and very rich, so rich that we don't need to step into diagnosis. Thank you.
Thank you. We have Pharmacist Valentine Odili's hands up. Pharmacist Valentine Odili, you can ask your question.
All right. Good evening, everybody. Can you hear me?
Yes, we can.
So I just want to weigh in on the question I was just asked, and to bring a kind of balance. I agree with the person that asked the question. Usually, if you're talking about drug information services, it has to be drug related. And like the presenter said, usually you categorize questions, and there's typically no categorization as for diagnosis, really. which shows that it is actually not in the purview, all right, to make diagnosis. All right. So usually what we do as pharmacists answering drug information questions is to see how we can get the drug aspect, okay, of therapy or whatever question. So that question that was asked, though it's actually typical of it's a typical diagnosis question. If we had gotten some deeper background information about that patient regarding drug therapy, then you could come through that, okay, to say, well, this drug is been known to be used for this kind of diagnosis and that kind of diagnosis. Because, the fears of the person who asked the question is this: you're documenting. And if you document that this is what is wrong with the patient and it is wrong, you're making a diagnosis, and that is not your job. Okay, so I quite agree with the person who asked that question. In drug information services, you have to be very careful. All right, don't try to make diagnosis except you're trying to answer a drug information question particularly. All right, and so you can give different scenarios, and this is what is used for, this can be used for this, because you have data and references to back up whatever you're saying. So it's not just you saying it, but you have references that can be checked. All right, and like the presenter said, yes, there are certain kinds of minor ailments that you can respond to. Okay, you're responding to the symptoms, and particularly using over-the-counter medications, and maybe in some other clients, pharmacy-only medications, which you have the authority as a pharmacist to prescribe. All right, so we need to be very careful when we're doing this kind of things. I understand the fears of the person who asked that question. I must be careful. I'll give you an example. It's like using the BP monitor and a stethoscope. There have been times in the state where I practice where some medical personnel, Bacillus medical personnel, have gone into pharmacies and they're asking the pharmacists not to use BP monitors and all that stuff. You see, if you're a pharmacist, you say, look, I'm not making diagnosis with this. I am monitoring drug therapy, and it's well within your purview as a pharmacist. So use the stethoscope and the SPIG to monitor a patient or a patient's blood pressure and all that. You can do that, but you cannot make diagnosis with that and check heart rate and all that stuff. Okay, but you can use those tools to monitor drug therapy, which is well within your purview. I think we should get that right and strike the right balance, like you said, not fall prey to these people who want to get us out of practicing what we ought to be practicing as pharmacists. Thank you.
Thank you, Pharmacist Odili. So we have pharmacist Folashade Lawal here. Welcome, Ma. It's good to see you and have you here. Please, you can make your comments. Thank you.
Kindly unmute, Ma.
Okay.
Yeah, Dr. Lawal, unmute. Yeah, muted. Yeah.
Okay.
Yeah.
I was struggling with this, trying to unmute, and it wasn't just allowing me. So sorry, I had to join late. I already explained to pharmacist, but the little I met was quite interesting. I just want to chip in one or two things to drive home some of these points. I recall an elderly client, very elderly. He had hypertension and all that. So he came coming to me, was very angry. He said that cardiologist thought he was mad. They now put him on a medication for mad people. What happened was that he had hiccups, and the cardiologist placed him on chlorpromazine. He now went somewhere to ask for the function of chlorpromazine. I think he met a young pharmacist. That one said, for mentally ill people. That is all. He got very angry, and he wouldn't take the medication. So he came to me to say the cardiologist I referred him to place him on a drug for mental health, that he did have mental health problem. So sometimes the way we present this information is very key, especially like they said, we in community practice, we see a lot of cases. When I was much younger too, in practice, one woman came with the intention to fight me because I was not watching some blood reports the previous day. There were 42 of them. And I tried to explain. He wanted to know who could have given the other the infection. And I was like, it's not likely anybody gave this. This is the physiology of a woman. It was just some simple infection. They were not even strictly STIs. But I don't know what he told his wife at home. And she came saw me. She said, when she now saw me, she calmed down. She said she thought it was one girl that wanted to take her husband from her. I was telling her husband that she was the one that gave him the infection. I said, no, I just know what I said. So we must be careful what we say. We must know our bounds, like we have all been told. We must respect the other professionals, and they too will respect us when we respect them and appropriate the information. Drug information is very critical. We must know what is on the mind of the inquirer, very important. And we have to follow the steps to get to the root of the matter. Otherwise, we might create a lot of problems because the inquirer might just be witch hunting somebody somewhere and might just fall into, make the person more vulnerable. Thank you. God bless you. It's been a wonderful evening.
Thank you very much, Ma. Yes, so I just want to chip in one or two things. When we're responding to a drug information request by a professional, especially when it's a professional, it's always preferably to respond by email. And even if you are responding with a phone call, when you are getting the requester's information, get the email, and always when you make the phone call, always send an email reiterating what you have, your response. One, it helps with documentation, and two, it protects you in the sense that, okay, this is my response, unlike a phone call where there's no documentation. So that's just my 50 cents that I'm adding. So yes, I don't know if we still have any more questions. If in the absence of any more questions, I would like to call on Dr. Joseph Madu to give closing remarks.
Okay, well, good evening. Can you still hear me, please?
Yes, we can.
Good evening.
Good evening, Dr.
I thought
Madu.
I've already, yes, I thought I'd already given my closing remarks when I spoke.
Okay.
I didn't know I'll be called again too. But let me still thank, I discovered you were referring to my lecturer as Mrs. Valentine Odili. That's a professor, somebody who produced us. Let me thank him so much for coming on with us, because we appreciate this type of things. And let me also chip this in. I remember the presenter was talking about documentation. And I want to remind us that CPAN have some documentation tools. Let us always look at them and see if they are appropriate for our setting, so that we can start using them. Because whatever we do in theory and we do not make it get to end products, then it is useless. Thank you very much.
Thank you, Dr. Madu. Okay, so in light of that, we're going to take a closing prayer, and I'd like to call on pharmacist Abbas Ibrahim to give the closing prayer. Okay, I think if he's not able to unmute, then I'll call on pharmacist Abdulmin Issa to give the closing prayer.
Good evening.
Good evening.
Okay, let us pray. We thank you, God, for bringing us to the end of yet another very interesting and educative session, a special edition of the clinical meeting of our great association presented by one of the specialty group. We pray the word of learned today will increase us in knowledge and arm us better in providing drug information to our patients, our clients, and colleagues, and whoever will ask us. We ask you for this and others, and we pray that you make us to sleep well and wake up stronger and healthier. In God's mighty name, I have prayed.
Amen.
Amen.
Thank you very much. So I want to wish everybody a lovely night, and thank you once again for your patience, for staying for the lecture, and I hope you all have a good weekend. Thank you, and bye-bye.
Bye.
Bye. Bye.
Good night.